I am the I am the president of the Munson Healthcare Foundation, and I appreciate all of you joining us today. I know we have some board members, we've got donors, we've got volunteers, and we've got some staff members that are joining for today's presentation. I will let you know that Dr. Gary Raja, who is one of our speakers today, our key speaker, he is with a patient right now. So he hopefully will be able to join us shortly. But I think that we will be able to at least begin the presentation. John Cox is with us as well. And then we will accommodate Dr. Raja as soon as he can join us. Just a little bit of housekeeping, if we will. If you'll, we will have the opportunity to do Q&A, but we will do that at the end. But if you'll notice at the bottom of your screen, and sometimes you might have to move the cursor to see it, there's a Q&A option, and that is where you can click on that, enter your questions, and then at the end of the presentation, we will be reading those questions, and then either Dr. Cox or Dr. Raja or John Cox will be answering the questions. So if you have any issues with that, just send a message. So with that, I am really pleased to introduce John Cox. He is the Executive Director of Surgical Services for Munson Healthcare, and he has been working with us for quite a while now to communicate with donors, with board members, with the community on all of the needs that we've got around the comprehensive stroke program that we are building here at the medical center. So with that, I will turn it over to you, John.
Okay, thank you, Deborah. Good morning, everyone. I'm John Cox. I'm the Executive Director of our Surgical Services for the system. And I'm also the administrative lead for the stroke program. Work closely with Dr. Raja and quite a few other people, quite honestly, both at the medical center and across the system to launch the interventional stroke program, which is different than stroke programs. So a lot of people think that Munson Health System, both at the medical center and our community hospitals, have already had a stroke program, and we did. What we did, though, is we are limited in what we could do to help somebody that was having a stroke event. Typically, if somebody was in the process of having a stroke, we would give them a clot buster, TPA, to try to break that clot up. And at the same time, we'd ship them as quickly as we could down to another center. And for the majority of our patients, that was Spectrum, which is about 2.5 hours south of the medical center. And then some of the hospitals, Cadillac, Grayling, and Gaylord would sometimes ship more toward the Saginaw area. So just to kind of put in perspective, clot busting works on about 10% of the patients. And we would have about 500 patients a year present with stroke symptoms. And some of those patients would qualify for intervention. Some of them would not. Their stroke had already progressed to the point where there wouldn't be a benefit from trying to intervene. So this kicked off just about 6 months before COVID. This was presented to the board, that this was an initiative that we really felt was important to Northern Michigan. Obviously, treating strokes a very time-sensitive situation. The quicker we can intervene, the more brain cells we can save. And to put in perspective, for every hour you're having a stroke, the brain ages 4 years. And the brain loses about 2 million neurons a minute during the stroke event. Blood flow of your brain is your speech center. You can imagine how devastating it is. And many people know others who have survived a stroke but have deficits such as movement, talking, that sort of thing. So we felt it was very important, given how isolated we are in Northern Michigan and not having an interventional site, to move ahead with that plan. And then COVID hit. Obviously, that presented a lot of challenges operationally to our system, but also financially to the system. But again, the board felt strongly that this was probably one of the few projects that weren't put on hold, and we moved ahead with. Dr. Raja joined us kind of right in the middle of COVID, and helped us start setting up this program. And to help bring in additional expertise, we partnered with Michigan Medicine. So U of M physicians, APPs, staff members were very involved in training our teams, working with us, sharing information, really helped us kind of shortcut some of those steps where we'd have to try and figure things out ourselves. So it's been a great benefit, and they're still very involved kind of in the background with our program. We started doing interventions approximately a year ago. We officially opened up in October, and I'll talk a little bit about that here in just a minute on the slides. But to put in perspective, in the last 12 months, we've done a little over 100 interventions. So Gary and his team have been very busy. That's busier than most programs like U of M, Beaumont. We're a very high volume center just because of our location. There's nobody else across town that's also doing it. So it's a great benefit. And what we found is before we launched the program, we looked at the past 30 patients that we had shipped down to Spectrum for an intervention. Unfortunately, what we found was half of them got there too late to even have an intervention. Their strokes had just progressed to the point where there'd be no benefit. And so think about that. Over 100 patients have been served so far with this program. And if we would not have had it here, half of those patients would not have received an intervention after their transport. And for the other half that would have, being able to provide intervention so much earlier absolutely had a benefit to their outcome, improve their chances of going back to a normal lifestyle. The next slide, please. Next slide. So just a little bit about Gary Raja. We have been very fortunate. Gary did his bachelor's at Grand Valley. He did his medical school at Detroit Medical Center under Wayne State in Detroit. He also did his neurosurgery residency there in Detroit also. Then after that, he went for a endovascular fellowship at the Gates Center in Buffalo, which is one of the top 3 stroke training sites in the country. And so really state of the art. Quite honestly, the techniques we use now were developed at the Gates Institute. And so Gary really had the benefit of getting world-class training. And we're pretty excited that we are able to bring ahead of our program somebody of his caliber. So I'm hoping he's going to be able to join us here soon. As mentioned, he's in a case, but I think he's going to be able to get in here hopefully soon and jump in. Next slide. So a little bit about Gary. He came from Lakeview, so just north of Grand Rapids, small town. He's a very normal guy. If you've met him, staff really like him, patients love him. Down to earth, grew up baling hay on his grandfather's farm, and just a super person to work with, and has just a passion for bringing these services to Northern Michigan. And I'll get into that decision. But, he's just texting me now, just finishing up a stroke. So he'll be joining us in a few minutes. But again, he has local ties to Michigan, certainly recognized the deficits of the service not being offered in Northern Michigan. And it's one of the reasons he chose this area to bring his family. And he's married and has 4 kids. So he's a pretty busy guy, even when he's not here at the hospital. Next slide. So we officially kicked off the heart program during World Stroke Day in October of last year. But know again that we really just did not want to postpone offering these services. So we started with one of our older biplane labs. And a biplane lab basically shoots an image of the brain from 2 different directions, giving Dr. Raja a better 3D image as he's moving catheters and such through somebody to get to that clot site and remove the clot. Next slide. So just a few things, we've had a lot of education, and this was one of the ones we did in Traverse City, where we're educating people. And not only did it help people understand what we're doing and the technology and expertise we brought to Michigan, but one thing we've just found out as we're reviewing our numbers is we were looking at the total number of strokes coming into our system, all our sites. And in the past years, it's been about just a little over 500 strokes. All right. And so not all of them are intervention candidates. Some of them we can treat medically, but over 530, 540 strokes. When we looked at the first 6 months of this year, our system already has done 480 in 6 months. And that's all about the education, having better diagnostics to recognize what's going on with these patients. So literally, it's not that we're having twice as many strokes. It's that we're now, the public, our physicians have better tools and more awareness, and they're coming in with stroke symptoms, and we're able to treat them. Next slide. So this is Pat Hines. Some of you may know him. He's a past board member at the medical center, but he had a stroke event, and his story's on our website. But a pretty healthy guy, and went to the Army Navy football game, and a stroke caught him right beforehand. And literally, he's alive because he was 2 blocks from Jefferson Medical Center, and he got immediate care. But still, it's been a long recovery for him. He still has deficits that he's working through. But again, his story's not unique. When you think about somebody who has a stroke, confined to a nursing home for many, many years, their quality of life isn't something that most people would be happy with. Very difficult for family. So when you hear these stories, it just gives you a great feeling when we see the good outcomes. I've rounded with Dr. Raj and to see these patients walking, talking, moving around. And one I saw a couple of weeks ago could not talk, couldn't move left side of her body. Watching that case, and then they start improving, some of them immediately right on the table, start talking on the table, Dr. Raja moving their left arm. It's a medical miracle when you see that happen. Next slide. So this gets into part of Dr. Raja's choice to coming to Northern Michigan. So you see the dark area, and that's kind of where the higher rates of stroke death are. And this is from American Heart Association, and they also are very involved in stroke. So you see across the south there, you see that really dark area, and they call it a stroke belt. And then also in Michigan, and we'll zoom in on it in a minute, you can see up there in Northern Michigan, we have our own stroke belt. And, there's a lot of things that contribute to stroke belts. One of the main things are access to a medical center that can intervene, but also to, it's lifestyle, diet, smoking, all those kind of things that contribute to a higher stroke risk. But you can see southeastern U.S., it's really a difficult area. Even though there are stroke centers, there's a lot of rural area out there like us in Mississippi, Alabama, that sort of thing, where you have to travel significant distance to get to an interventional center. Next slide. So this is kind of a close-up of Michigan. So you look on the right, and you can really see that stroke belt. You can see our hospitals for the Munson system. And what we're really, the goal is develop a stroke net. So, some of the equipment we have that we've been fundraising for are the biplane imaging labs. And these are very high-tech labs. We actually were able to just get the next generation that was released by Siemens out of Germany. And we were, I think we got the third or fourth lab in the United States with this generation. And these labs can interact with robotics, virtual reality, all kinds of other technologies through software enhancements and such. So we really wanted to get the very best. The other thing, and we'll get into it in a few other pictures, is you just get much less radiation, but much better pictures. So a huge investment in technology. So Dr. Raja has the best tools available for him and his team. But also we're investing in special artificial intelligence software. And we actually just installed this software. It's been at the medical center. We just installed in Cadillac and Grayling, and we're going to be installing at our other sites. And what it does is allows us to very rapidly acquire the images from the CAT scan, which is our main diagnostic tool for our stroke patients. And literally those images, while that patient is still coming out of the CAT scan device on the gantry, they upload to Dr. Raja and other providers' phones and the ERs and such. So decisions can be made very quickly. We also are looking at expanding the types of imaging we do on the CAT scans at these sites. So the goal is to create a stroke net with our system hospitals. So even though the interventions are maybe done at the medical center, we can make very timely decisions for our patients at all our sites. And that's what we're moving to now as we upgrade the technology in our community hospitals. And what that also does is, you know, it's not uncommon when we get an image that a decision's made to transfer somebody to the medical center. But without advanced diagnostics, sometimes we can rule out those transfers where somebody's already proceeded to the point through their stroke event that there's no benefit to that transfer because we will not be able to intervene. And then we want to save the patient, that family, that transfer, and being away from home when they could be cared for in their community. So the goal is to provide the right care close to home. These advanced diagnostics, this artificial intelligence software that we're installing in our communities will help us do that better and really make sure people are in the right place where the care they need. On the left side, this is where people are within an hour of an interventional center. So that's the yellow area there. And so you look to the north and you can see that the travel times are significant. I think about 30 to 40% of our patients will be transported by air asset, either our helicopter or our fixed wing, prior when we were sending people downstate to Spectrum or other sites. But, you know, if you live here, you know our weather, you know, and so air transport's not always an option. In fact, frequently it's not, especially during the winter. And so, you know, 2.5 hours, depending on what site we're transporting from. So just kind of give you an idea of the savings. And then Dr. Raj is here, so I'm going to hand it off to him. Dr. Raj, I was just talking a little bit about these maps. So I gave an overview of the maps. Maybe you could kind of pick up on how this impacted your decision on coming to the Munson Health System. All right, we lost them. I'm sure we'll get them back here in a minute. I'll keep going. Next slide, please. Oh, hey, Gary.
Hey, can you hear me?
I can hear you now. So I'm going to hand this over to you. I was just going over the slides that showed the Michigan map and how that impacted your decision on, you know, where you wanted to practice and be involved in setting up a new program. So it's just on the American Heart Association maps if you want to take the next slide or elaborate on that.
That's fine, thank you. So I'm just walking back to my office here. Thanks for letting us talk here. So the maps John had up previously, we looked at, and one was from the CDC. The other one was American Heart Association. And we kind of just saw that the stroke death rates in Northern Michigan were very out of proportion to lower part of Michigan below the knuckles. And so when I was looking at, you know, where I wanted to go, where I wanted to practice, I said, well, I can go downstate. I wanted to come back to Michigan. I'm a Michigander, did most of my training here. But I said, where's the right place to put a new stroke center like this? And it 100% was Northern Michigan at Munson Medical Center. I think that adding another physician that does these types of procedures downstate, while always helps the call pool down there, I don't think it necessarily helps the overall healthcare of the state in that way, because you're still leaving a large population of people uncovered by these stroke therapies, which can be life-saving, function-saving, etc. So we decided to go, and John and I talked, and Munson and I talked, and ended up in northern Michigan here, and have been very excited with what we've been doing. This map here that is being displayed is essentially 11 months worth of thrombectomies and stroke procedures done acutely, so emergently, at Munson Medical Center since our launch last year. And you can see there's over 100 patients there. We've covered the northern part of the state, including the Upper Peninsula, and it's pretty amazing. You know, for a new center to do over 100 procedures emergently for stroke essentially says, you know, that it was a very needed thing. We also doubled our diagnoses of stroke as well, which we'll kind of show you here as well, for like small strokes and strokes that don't necessarily need a procedure, but need to be treated to help prevent the next stroke. To give you just to put 100 or more acute strokes taken for thrombectomy in context, you know, there are comprehensive stroke centers that have been longstanding downstate that maybe only do 30 procedures a year. So, you know, we're 3 times busier than some centers already downstate, which would put us on par with, you know, being one of the busiest centers in the state. Our first year, our first 11 months, which is, can we go to the next slide? Thank you. Sorry, I don't have the control of the slides here. So this is what I was kind of talking about earlier. We have, Spectrum was kind enough to share some numbers with us, as well as Michigan Medicine, as well as our own medical center in 2020. And that those first 3 columns are 1 year's data. So there's the stroke volume at the top, which is any stroke, and then the thrombectomies performed. So Spectrum obviously serves Metro Grand Rapids. Population-wise, pretty significant amount of people there. At U of M Ann Arbor does about half the strokes that Spectrum does. And then Munson Medical Center was on par with Ann Arbor, Michigan, around 400 to 500 strokes a year coming in through the emergency room. We only did thrombectomy 30 times that year because the program only started at the end of the year. So that's only really 4 months of thrombectomy data for Munson and 2020. But we're over 100 for a year, which puts us, you know, essentially on par with Michigan Medicine and Spectrum for acute stroke procedures. And the thing I really want to draw your attention to is look at Munson Medical Center 2021, January to June. That's 6 months worth of stroke admissions, and it's already more than we had diagnosed the previous year. So we did that in 6 months. And so we're catching more strokes, we're identifying them better. And I think a lot of this is due to, you know, many of these community outreach things that John and I have been doing, as well as many other people at the medical center, kind of getting stroke on everyone's mind. And that if you're having a stroke, even if it's COVID, you got to come to the hospital. You know, even if it's a minor stroke, you know, your face is numb or something like that, you got to get checked out. And I think through new protocols and imaging things that we've done here as well, we've increased the amount of stroke we're diagnosing, and that's a great thing. You know, some of these can be transfers into the medical center for stroke, which would add somewhat to the numbers, but I think overall it's just a simple awareness thing that has really helped the medical center, because these strokes, you know, we didn't all of a sudden have 400 to 500 strokes for the last several years, and then now there's 900 because of anything. There weren't 400 more strokes this year, you know, just in general, out of the blue. They've always been there. It's just probably they weren't recognized. And so I think recognition has become a lot better. Next slide. So at Munson now, with our interventional and surgical capabilities for stroke, you'll come in, you know, a patient will come in through the emergency room. They'll be assessed by our advanced stroke team, right in the trauma bay, right in the emergency room. This takes place in, you know, a matter of minutes on arrival. You know, by about 5 minutes after being there, their case will have been seen and discussed with neurology, neurosurgery, as well as advanced practice providers, possibly the ICU. and they'll go for imaging. The ED doctors are also involved in their triage, obviously. And in the CT scanner, they'll get special CTA images that will look at the blood vessels, but then another image called a perfusion image will tell us kind of and help us to localize and pinpoint the area of interest related to stroke. And I'll show you a little bit about this later here, but essentially what that means is that in the CT scanner, we now have software that in real time, as the patient's getting the scan, is sent to our phones, our handheld devices, in a HIPAA compliant way that allows us to make decisions quickly. We know that time is brain. That's the whole point of putting a stroke program in Northern Michigan. Every hour we wait with someone having a stroke, you know, for transfer or for looking at images or things like that, their brain ages 4 years. You know, every 10 minutes we wait, it costs the healthcare system $10,000 more. The patient loses 39 disability-free days. You know, all these statistics have been worked out as to why time is brain and why it's so important to do these things as quickly as possible. Next slide. And so here's an example of the pictures that come to our phone. You can see the green is the area that's at risk. It's a large section of the left side of the brain. The red is the area that has already undergone irreversible changes. And so by looking at these, we can sort of discover and pick which patients will benefit the most from thrombectomy or from a stent and opening up their blood vessel acutely. And so this patient would have been an excellent candidate. There's a small amount of tissue that's died, but there's a lot of tissue that will die if nothing's done within, you know, the next 30 minutes to an hour. And so this is someone where when these pictures come across my phone, I'm calling my team in. It's usually in the middle of the night, 3 a.m. and they're running in. They have 30 minutes to get in, and we have the patient on the table within 30 minutes. You know, that's how this works. Next slide. So now we're using this company called VizAI, which is just like the previous thing I showed you. It uses AI as for artificial intelligence, and that artificial intelligence, I like to say, cuts out some of the middle work. Meaning that the software can detect when there's a big blood vessel in the head occluded. It sends off an alert, ping, 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 wakes you up out of your sleep. It could wake, you know, a sleeping rhinoceros, it's so loud. And it essentially alerts the whole team. So I have this software. My stroke team people have the software. The neurologists have the software. The advanced practice providers have the software. And now I'm happy to say that as part of this Munson Stroke Net for the healthcare system, there's other centers in Northern Michigan that also have this software. And so Grayling, Cadillac, Gaylord, those hospitals are able to get immediate information in real time that's also seen by our physicians over here so that we can make the right decision for the patient in the quickest amount of time, whether that's staying at the community hospital or whether that's transferring to Munson Medical Center for a clot evacuation or for a thrombectomy or for an emergent intracranial stent. These things all happen now in real time. And so it's truly amazing. The other thing that the software allows is it detects blood clots in the brain, so brain bleeds in real time. And so, you know, I'll tell you, just yesterday, we had a patient that I took for an evacuation of a big clot, subdural, that the software was so quick in identifying it. They were still on the table and our team was down there bringing them up to the emergency room, bringing them up to the operating room to have surgery before the images were even reported to the emergency room doctor. And so that's an example of how much time can be saved. And when, you know, when it's your loved one, when it's your family member, you want them to have every option of having a good outcome. So next slide. We look at new imaging to old imaging. When I arrived here 13 months ago, there was the biplane, I think, was from like the 1910s or something. It was from the 1990s. But it's the X-ray machine that we do the procedure on. It has to be very good. It has to have very clear resolution. And, you know, the patient may only get the procedure or the X-rays once, but my staff and we get it all day long, and that's radiation. And so in order to keep everyone healthy and working a long time and get the best outcome for the patient, the medical center invested in two beautiful machines that are state of the art. There's only, I think, 7 of them, maybe 10 of them now in the country, and 2 of them happen to be in Northern Michigan. One is installed and we're using it. The second will be on board here in October. So these machines are made by Siemens Corporation. They can be interfaced with the perfusion software that we're using. They can be interfaced with robotics down the road. Just look at the quality of images. The previous imaging is the grainy one on the right, and screen left, you can see how clear and crisp, and you can see these catheters and wires as fine as hairs through bone that I'm looking at when I'm doing this procedure. So, I'm using my 2 hands to control 4 different things. The last of which is a little wire the size of a hair within 2 millimeter blood vessels in the patient's head. And so these are thin, fragile vessels that you can essentially see through them if you're looking at them under a microscope. You need to be moving wire and catheters very carefully when you're doing this, for the best outcome. Next slide. Again, just look at how crisp and clean the images are. Left side is new images, right side is old images. It's night and day. So we're happy to have that software here. We're happy that Munson's committed to that. We're happy to have these biplanes, and part of this is continuing to fund state-of-the-art technology so that we can continue to help the population up here. Next slide. So new procedures to date. I am a neurosurgeon as well, so I do all of the trauma and brain tumor, spinal cord stuff, traumatic spine fracture things that the other neurosurgeons here do. I do that, and then in addition, I do the stroke stuff. And these are just stroke-related procedures that are new to Munson Medical Center in the last 11 months since my arrival. And you can see it's a lot of procedures. Embolizations, we're able to block off like a nosebleed through the wrist with the patient awake with nothing more than a poke. For those real hard to get to posterior nasal bleeds. There's many things outside of stroke that these endovascular capabilities allow us to do. We're clipping aneurysms, removing AVMs, we're coiling aneurysms, and then all of the stroke stuff that I was telling you about. Next slide. You can play that video. I'll have you fast forward a little bit here. Just click ahead. Yeah. So right there, this is a 70-year-old gentleman who's having a big left-sided stroke, that red area in that top right, screen right. Go to just slide it forward a little bit more, please. Keep going. Right there. Perfect. Thank you. That's okay. We'll see it again. So these procedures are done awake. They can be done through the leg or through the wrist. This is me at Buffalo. My colleague is the gentleman that you see more in the camera. I'm up by the leg. You can see the patient moving a little bit. It's not overly painful or anything like that. And that's why we're able to do it awake. And that gives us a lot of information. It can be done asleep as well. But again, time, it's quicker to just bring the patient there and do it awake. Here you see that the MCA vessel is blocked off. On the left side, you'll see it again here. What I really want you to look at though is how fine the wires and catheters are that are going up into the head behind the eye. You'll see a better view of that here as we zoom in. And so the goal here is to be able to manipulate a wire that's hair-like through a 2 millimeter vessel that's occluded without popping out of the vessel and somehow going through the clot, so that you can try to pull out the clot and bring up a larger catheter. And we hook these other catheters up to pumps outside the body. And just like, a vacuum, essentially, it draws about 25 meters of pressure, and we try to latch the clot and suck it out. There's some other techniques we can use. You can fast forward a little bit there on the video. Yep, keep going. Thank you. Thank you. Keep going. Okay, good. Back up just a touch right there. So now you can see we've opened the vessel, but there's still an area that's very, very narrow. It's stenotic. You'll see right here in the middle there. And so now we need to open that up. And so we're going to place a 2 millimeter stent in the head from the leg with the patient awake in a minimally invasive way. That's essentially a reach of like almost 6 feet. And so you can imagine how precise this needs to be. And you see the wire going up there. And this is where this high definition, very good X-ray quality comes into play in keeping people safe and getting them the best outcome. And so here you'll actually be able to see the stent open. You know, 2 millimeters is tiny. So stents across the stenosis. We've zoomed in again. And I think the next set of pictures, you'll see it open. The stent's mounted on a balloon. And so we just inflate the balloon, and here you go. The balloon's between the 2 black markers, and you'll see the stent slowly inflate. And that stent will stay there. And now look at the vessel now after we inject. It looks brand new. The patient has essentially, pristine circulation now. So we can go to the next slide. This is someone who, maybe over the next day starts to move their right side of their body. They start to say a few words. By the time they leave the hospital, they're walking and they can lift their arm against gravity, and they're speaking fluent sentences. And by 90 days, this is probably someone who has, minimal residual deficits left and can return to work. So you've taken someone from being in a nursing home to allowing them to return to their families and possibly their work, and at least, maybe retirement, whatever it is that they were doing and wanted to do. And so this is a patient we did here at the beginning of the program. She's been a very strong advocate for the program. She did excellent. She's a 56-year-old lady from Sutton's Bay. Her husband found her down walking the dog, unresponsive, not talking, not moving one side of her body. Young lady. She was down about 2 hours before we found her, and we brought her in, ran her through our stroke protocol system here, had her in the IR suite, and pulled her clot out through her wrist in about 30 minutes. You can see the clot in the middle picture there. It's roughly 1 centimeter long. That's one of the devices that we can use, and her vessels opened up nicely. Next slide. She left the hospital walking, talking, which is not how she came in. And this is me with her in clinic. You can see she has a little walker there for stability. She no longer uses that. She just called me for a 1-year follow-up, and she didn't want to come in to see me because she said she was in her garden and was, having a good time in her garden, doing some gardening, and was very happy, no complaints. And so she told me she'd reschedule another time to come in and say hello. But, someone who did an excellent, phenomenal, it's what makes this job fun. Next slide. And so the work, in a sense has just started, but we've come a long ways to how we treat stroke in Northern Michigan. Our work is not done. This is something that needs to be fine-tuned. And, we are already one of the busiest centers in the state. The next step is that we get the proper support and things we need to make this and take this to the next level. Again, 100 patients, over 100 patients in 11 months is just tremendous. No one ever thought that there were that many patients up here suffering from this type of stroke. Next slide. I also treat ruptured aneurysms, brain bleeds, things like that. That's the other side of stroke that a lot of times gets forgotten. It's called hemorrhagic stroke. We won't spend much time on it, but part of being a stroke center and treating all of this is treating all kinds of stroke. So not only the lack of blood flow, but also bleeding blood vessels in the brain and things like that. And so I treat that as well, both with surgical techniques and endovascular techniques. Next slide. We have a lot of new software techniques, imaging modalities here at the medical center that will allow us to continue to treat patients at a high level. And in fact, that lady that I was telling you about earlier that had the stroke, the 56-year-old, she was found to have a hole in her heart, a PFO, that actually was able to be repaired several months down the road by our cardiovascular team here. So, stroke patients require, cutting edge techniques across the hospital, not only for the acute care when they come in under duress, but also for other things that may be the cause of some of their problems, like holes in the heart, things like that. So this is an aneurysm, a very big aneurysm. It's the size of essentially, it's bigger than a golf ball. You can imagine this is very dangerous to have in your head. If it breaks open and bleeds, it's consistent usually with death. And so we try to treat them when they're this large before they break open and bleed. And we can do that again. This patient went home the next day. I was able to treat them with a stent and coils through their leg. Next slide. You know, this field is always evolving. It's one of the most fast-paced fields in terms of research development. These stroke techniques have essentially came out in 2015 as being the standard of care. And, you know, people had been developing catheters since the early 2000s. Catheters from the early 2000s compared to now look completely different. They're so much softer, so much more trackable. This field changes in an instant rapidly, and that's why we're able to progress so quickly. And that's also why it stays so exciting for the physicians, the surgeons that do it, because you know the next newest technique in catheter is just around the corner. And what that means is getting someone their treatment safer, quicker, and faster than you were even able to do it a year ago. And that's the amazing part. Next slide. We're always looking to innovate. This is Buffalo. They did a great job of innovation. They're one of the leading stroke centers in the country, and essentially the model of what most stroke centers base themselves off of. We're trying to do this at Munson as well, you know, albeit on a smaller scale, to continue to stay innovative, to look at ways to improve the process, to help our patients, and we are doing this daily. Next slide. We already have companies talking to us about, you know, what virtual reality will look like with these new biplane imaging suites that we have. Again, we're only one of a few centers in the country to have these state-of-the-art machines. And so there's a lot of people who want to come up and look at them, and a lot of people that want to collaborate with us to use them in a way with robotics and all the advancing technologies coming down the road. So exciting times for the medical center and for Northern Michigan. Next slide. You know, I continue to write. I think, you know, research and publications, peer review process is what keeps us knowing what's going on in our fields every day. It's conferences and teaching and lecturing and getting the word out. And so, you know, that's also part of being a comprehensive stroke center. And so, you know, we have to continue to add to our field. Next slide. I'll leave you with that. Again, apologies for my late arrival. Thanks to John for getting things started. You know, we are a great stroke center already, and we're only going to get better. So you know, this is our slogan. I didn't come up with it; they did here in the Munson marketing department, but I love it. Minutes matter, make it Munson, and we're all doing amazing things. Thanks.
Thanks, Gary. I just want to kind of wrap up, and then we'll go to questions. One of the questions that are commonly asked, well, how much are one of these labs? So the equipment for one of these labs, and we will have two of them, is $2.5 million per lab. And then about another $2 million put into the room to get the room ready. And then it's not just a lab, it's anesthesia equipment, ultrasound equipment, computers. There's a lot that goes into it. These machines are run off very large computer banks that need special cooling. And so it's quite an investment. And so Munson agreed to invest in the first lab. They challenged us and the foundation to go out to the community and help pay for the second lab that is in process, because you really need two. I know we had one day on a Saturday where Dr. Rashi had 3 strokes come in a very close time frame together. He is able to do the first 2, but you know, decided that third person would get an intervention sooner if we flew him down to Grand Rapids, given there were 2 in front of him. And so those are reasons to have 2 labs. We can stagger patients, have the other one on the next lab ready to go, catheter sheaths in, that sort of thing, to move quicker. So that's why we are looking to put the second lab in. The other thing that I wanted to just highlight too is it's a sizable investment just in supplies. So as you hear Dr. Raja talk about catheters and ones, they're close to $1 million worth of supplies for one room. He needs all the different sizes, some wires, because he doesn't know until he starts getting into a case what he's going to need. May have one stent or device network on these labs. In all total, we've invested over 11 million right now into the stroke program. We've hired approximately 20 full-time positions. We are hiring additional doctors and PAs, nurses, to further increase the resources we have around this program. And also, I guess, want to note that, it's not just the stroke patients that benefit. When you add these kinds of neuro specialists to the hospital, if somebody has a neural trauma or other critical issue, these are specialists that have really raised our resource level in our ICUs to help deal with those other type of injuries beyond stroke. So really a benefit across the board to our system. And as Gary mentioned, we're seeing that as we roll out the new technology in Cadillac and Gaylord and Grayling. We're going to be evaluating the other sites too, and looking at moving that software out to additional community sites. So again, I just want to emphasize it's really a stroke net for our whole system, and we're investing across the board. And really the goal is to just be able to make decisions very quickly for these patients and give them just the highest level of care possible close to home.
Yeah, that's a good point, John, related to trauma and other things that the program provides. We just had a gentleman up here that had a traumatic laceration of the vertebral artery in the neck. Traditionally can be very deadly, life-threatening, and very hard to fix problem that we were able to repair with catheter-based techniques for him, and he went home with no related issue to that. So, traumatic injuries to blood vessels also can benefit from these types of therapies as well. So.
And then Gary, just one last thing, because I always think this is pretty fascinating. He doesn't just take clots out, he can put clots in. So he talked a little bit about the nosebleeds, but if there's a tumor in the brain, what he'll do is artificially create a clot with particles or glue to cut off blood supply to that tumor in the brain. And then it makes for a safer operation to remove that. And so there's been other individuals with bleeding in their esophagus, cancer patients and such. He identifies what the artery is, supplying that, where that bleed is. And then using different techniques, he'll create a clot or a blockage therapeutically so that patient will benefit, and we can control the bleeding or cut off blood supply to a cancerous tumor for removal, that sort of thing. So pretty interesting, some of the techniques he's brought here that, we never had access to some of these things before, and now they're here, and what a great thing for our patients. So with that, Emma, maybe you can, I can't see questions here on my phone, but if there are questions, we'd be happy to answer them.
Yeah, absolutely. We have one question asking, the number at Munson have increased. Where were those cases going before Munson could handle them?
Right. So that's a good question. Prior to this program's launch, the cases that were identified that needed a surgical procedure would go downstate, be flown by helicopter, meaning the helicopter had to come to the hospital, pick the patient up, fly them downstate. They'd need new pictures downstate at Spectrum, and then they'd go to their IR suites or ORs for their procedure. And that's how, all those patients were sent out of Northern Michigan. The issue with that is that transport time takes time. Obviously the helicopter is quick, but it's all the waiting for the helicopter to come here and go back and all that stuff. And sometimes it can't fly, and then you have to go by ground. That that makes the problem much worse. So time is brain, as we know, even minutes are mattering. So imagine transfer processes that take 3 hours, 4 hours, or longer. It's a big, big problem. And the other thing we've learned is that our patients up here, they come from very far away. So, Grand Rapids patients, they all live within, an hour of the hospital. So they're what we call last known well, meaning their time from when their symptoms start to the time when they get to the hospital is usually under 4 hours in Grand Rapids. Up here in Northern Michigan, our average last known well time, meaning from symptom onset to when the patient presents to physicians, is over 10 hours. And so we're already behind the ball just because we're so spread out in Northern Michigan. To then wait another 3-4 hours for the transport process puts the patient at a significant disadvantage. And that's why we were seeing that, maybe only half of the patients that got sent downstate even got a surgical procedure because it was too late for the rest. There's only so long that it's worth taking the risk of a procedure. If the brain, passes away before that time, then there's no risk left. There's no benefit left. It's only risk. So the second part of that question is we've now identified more strokes, right? It's not because the strokes weren't here. It's just because the protocols previously were not as stringent as what we use now to identify strokes and to triage them in a way. And so we're seeing that the stroke population, the stroke burden in Northern Michigan was much higher than what was previously thought. So those two things combined, kind of say why what we're doing here is not like a nice thing to do. It's not like something, everyone thought, hey, maybe a good idea. It's just something that's absolutely necessary. To give you an example, there's 3 stroke centers in Grand Rapids, 3 comprehensive stroke centers, right? All within 15 minutes of each other. All right. So if someone adds a 4th down there, that they're doing that because, it's fun to have one. It's good for the hospital, but it doesn't increase access to patients down in Grand Rapids because there's already 3 other ones within 15 minutes. Now you talk about Northern Michigan, where the next closest hospital is over 2 hours by car. I mean, it's a no-brainer.
Gary, could you maybe, to just in addition to that question, kind of explain how some of the patients, it isn't very clear sometimes that they're having a stroke. They might come in with headache or dizziness. It's not clear that they should go to imaging or get worked up. So can you talk a little bit about when you say things are more stringent now, we're doing more diagnostics, we're more rigorous, I guess, in talking to people and trying to diagnose what's really going on?
Yeah. So in the emergency room, we now have, essentially a code stroke. We're getting input from many different providers, neurology, neurosurgery, the advanced practice nurses, really looking at the neurological exams. And that's not to say that these things weren't happening before, but some of the new imaging modalities have also helped us, and we've lowered our bar. Instead of saying we're only going to look at really, really severe strokes, we're not only looking at those, but we're also looking at more minor strokes as well, and saying, well, we need to look at them when they have a minor stroke, because that could be the warning sign for the bigger stroke. And that bigger stroke could be tomorrow. That bigger stroke could be 2 weeks. It could be in 2 years. But we need to know, and we need to determine if we need to do something now or do something next week or do something in 2 years. And so that's where we've really stepped up the diagnostic portion of this, and identifying patients coming in with stroke symptoms is through a multidisciplinary effort amongst multidisciplinary team that has allowed us to identify, more strokes and to treat people appropriately.
Thank you, Dr. Raja. There is just one more question at this time. Someone is asking, are there equipment needs at community hospitals to support the stroke program?
That's a great question. Our goal is not to transfer everyone to Munson Medical Center in Traverse City. That's not the goal. The goal is to transfer those patients out of their community hospitals that need to be transferred. And so what that means is that
This Munson professional.
yes, professional building. You got to walk
That's
around.
closed.
Yeah, if you take the sidewalk here just around to the far side, you'll be able to get there.
Other side?
Yep, just walk up the sidewalk. Sorry about that. And so our goal is to keep people in their community hospital. And so what that means is that we need to have the proper way of triaging them. The same way they'd be triaged at the medical center, the same way they'd be triaged down at Spectrum Health, the same way they'd be triaged in Ann Arbor, Michigan, or across the country. And we need, the goal is to provide consistent care. And so the way that we're doing that is bringing things like Viz AI, these artificial intelligence software, the real-time imaging to the community hospitals, so that we have access to those images, so that we can help the physicians there in the emergency room and on the floors taking care of those patients with, decision making on as to whether or not a patient needs to be transferred or not. Part of that, and John maybe mentioned it earlier, is that we may need to update some of the CT scanners at some of the outside facilities. And why do we need to do that? Well, one, because the software that we need for the perfusion images, which can only be done right now at Munson Medical Center, which is why sometimes we need to transfer patients that maybe could have stayed if their perfusion is negative for a large area of stroke. But we only have that capability here at the medical center right now. So the goal down the road will be to have perfusion capabilities, meaning looking at how fast contrast is flowing up to the brain on a CT scanner at some of these outside hospitals, so that we can say, there's no benefit to the patient in coming to the medical center if they don't need to for post TPA or anything like that. They can stay in their community setting with their families, and that's the appropriate way to handle this. On the contrary, if there is a benefit, then we'll be getting them over here as quickly as possible. So.
Thank you, Dr. Raja. We did have one last question come through. Are we able to handle 100% of stroke victims and types in our system with this suite of technology?
Absolutely. Yep. Munson, before my arrival, sent out every stroke that was major. That means bleed, aneurysm, any intracranial occlusion. They all got sent out, whether they needed to be sent out or not. Now, I don't think we've transferred a patient in almost a year. I don't think we've transferred a patient for a stroke related reason. So we are full service. We handle everything. And we do brain tumors and things like that. So we're full service that way too. My partner and I, Dr. Pearl, handle all the brain tumors up here. And so spine tumors as well. This is a full service neurosurgery stroke department at Munson Healthcare, for Northern Michigan.
All right, that is all the questions we have. So thank you so much.
Thank you for your
Deborah, I'll
time.
turn it over to you.
So thank you to Dr. Raja and John for your time today. We know how incredibly busy you are, and we are grateful that you take the time to speak to our board members, our donors, our volunteers, and some other community members to share this information. Many of you have heard those of us at the foundation talk about this need. This is clearly a fundraising priority for us through the next fiscal year. We definitely see, as Dr. Raja and John have illustrated today, that this service benefits everybody in Northern Michigan. Every single person in our service area has the opportunity to come to Traverse City instead of having to go downstate. And we know that minutes really do matter, especially with stroke. So every patient who unfortunately might need this service that is in our service area will benefit from these services that are coming to Traverse City. And then, of course, the auxiliary services that we are taking to the other hospitals so that we can better serve those patients. So we are really grateful for all of you who spent time with us this morning to hear more about stroke, to understand the importance of this comprehensive project that we want to build upon in Traverse City, and then to take it to all of our service areas. All of Northern Michigan is going to benefit for sure from this comprehensive program. So we're grateful to all of you today, and please feel free to reach out to any of us at the foundation if you have questions or want more information. And if there are no more questions for today or comments, we will close the meeting. But thank you to everyone for your time today.
Thank you.